Welcome to our live webcast, Regional Anesthesia and Chest Wall Surgeries webinar. Thank you for joining us. My name is Heidi Border and I'm Meetings Manager for ASRA and will be the host for tonight's webinar. We are joined tonight by our moderator, Dr. Adib Owadat of the Cleveland Clinic in Cleveland, Ohio, who is going to introduce tonight's topic and speakers. Welcome, Dr. Owadat.
Thank you. Good evening, everyone, and I hope that you are staying safe and healthy. My name is Adib Owaidat. I'm the Regional Anesthesia and Acute Pain Fellow at Cleveland Clinic, Ohio. I would like to start by thanking the ASRA as well as PAJUNK for hosting and sponsoring today's event. I promise you to have an interesting and valuable educational time with Dr. Loran Soliman. Dr. Soliman is the Fellowship Director at Cleveland Clinic as well as the Director of the Acute Pain Service. He is the author of large number of peer-reviewed articles, editor of a regional anesthesia textbook, and conducting several regional anesthesia workshops at national and international meetings. This evening, topic will address the chest wall regional anesthesia procedures, a relatively new topic which is rapidly expanding in terms of literature and research. During the presentation, you can send your comments on the chat line. And if you have any questions, please submit it in the small text box at the bottom. And when finished, don't forget to click send. I will be collecting the questions and will discuss them with our speaker at the last 10 minutes of the presentation. Thank you.
Thank you. Thank you, Adib. Thank you for moderating this. And I want to join you thanking ASRA for providing the platform for this meeting, as well as for PAJUNK for sponsoring this meeting. I also want to wish everyone to stay safe. Hopefully everyone is healthy. I know it's a difficult time and it's a difficult time for all of us. And it's nice to be able to share with colleagues some of these presentations through the webinars. Now, as Adib mentioned, the topic we're talking about today is a regional anesthesia for chest wall surgery. Relatively new topic because traditionally, cardiothoracic surgery as an entity has not been a major focus for regional anesthesia procedures, unlike orthopedic or colorectal surgeries. Even though most of the studies, most of the literature suggests it is one of the most painful incisions to handle, and pain for cardiothoracic, as most of us know, can lead to major complication as reduced lung function, impairment of respiratory effort, atelectasis, hypoxia, reduced mobilization, DVT, and PE. And the literature, the surgical literature, have studies extensively the source of pain for this surgery. And it's variable, can be from the muscle that have been cut, rib fractures that happen during surgery, especially from retractors. The retractors per se, they can compress on the intercostal nerves and they can lead to an injury of the intercostal nerve, as well as the drains. And we all familiar, there's a lot of drains. Sometimes there's 8 to 10 drains after cardiothoracic surgeries, after transplant. So there's a lot of drains that are placed. So all these are source of major chest wall pain. And that pain is typically severe enough. More recently, during the opioid epidemic, cardiothoracic surgery actually has topped the list of procedures that overprescribe opioid on discharge. And when we say overprescribed, we usually use the 200 milligram equivalent of oral morphine as an indication of overprescribed opioid. So if we look at data that presented by the NSQIP data from 3 academic centers, and that was published in 2017, looking at surgeries with overprescribed opioids. The ones on the right, the orthopedic, here's a 200 milligram line. If we look at the right, if we exclude orthopedic procedures, which by far top the surgical procedure, if you exclude orthopedic procedure, you're gonna find that VAD, the video-assisted thoracoscopies, is the one to follow, with an average of the 600 milligram oral morphine. So that's 3 times what we call overprescription. So that tells you that it has been managed mainly through opioid. Now, if we look at JAMA also, in 2018, they looked at outcome of cardiothoracic surgery in patients with opioid use. And what they found actually, if you look at the incidence of chronic opioid patient coming for cardiac surgery, has been increased eightfold over the last 15 years, which again highlights the problem that it is a painful procedure. It has been managed primarily through opioid. So tell you that regional anesthesia got into this a little bit late in the game, but there's nothing called too late. We can focus. Now, if we look at these surgeries and who are the patients who are more likely to have open heart with a chronic opioid, you're going to find the valve surgery are more opioid than the cabbages, for example, and the younger patients. So typically it's your young patient coming for valve surgery who have high possibility of being on a chronic opioid. Now, if we look at the outcome, fortunately, there was not increase in mortality in these patients, but there is a significant increase in morbidity in terms of complication. So significantly, patients on chronic opioid have reported higher incidence of PE, blood transfusion, prolonged mechanical ventilation, opioid tolerance, hyperalgesia, increased length of stay, as well as the cost. So it becomes that what attracted attention to, shall we keep going with the way we're doing it, or shall we investigate regional anesthesia? Now, if we want to subclassify regional anesthesia, so if we think of the tissues as a source of pain, source of injury, transmitting pain signal to reach the central neuraxial, neuraxial, it gets modulated in the brainstem. We have to classify regional anesthesia as the central neuraxial, which typical for us is an epidural. However, it may be a spinal opioid. Have people have tried this? Discussed today, the fascial plane block. Fascial plane blocks are trying to disrupt the transmission signal along the peripheral nerve before reaching the epidural space. Now, since mentioned epidural, we're all familiar with the thoracic epidural. It's been used extensively for thoracic surgeries before, and most of us have that. Now, just to highlight the contraindication for epidural before we discuss why it starts to be fading out of favor. Contraindication are patient refuser, makes sense. Abnormal spine anatomy.
And Dr. Soliman, apologies for the interruption. It seems like we may be having some audio issues with your voice here. If we could have you switch over to phone audio, that may solve the issue. And to do so, at the bottom left corner of your Zoom screen here, or where your microphone icon is to mute or unmute, if you could click on that drop-down arrow attached to the microphone icon, you'll see the third option from the bottom there is switch to phone audio. Once you click on that, you'll see a window with a list of phone numbers. You'll just want to dial out to the top phone number on that list, and then you'll hear it ask you for your meeting ID, participant ID, and password. Once you input those, you will be reconnected.
So I need to stop sharing first my screen to do this.
At the top of your screen, you should see your view options there, and there you can find your microphone.
So I'm gonna go microphone. Can I try the microphone through the camera? Because I have microphone array, microphone C99, the street webcam.
Sure, you can try that as well, and we'll let you know if that works.
Okay, so I switch it to the camera's microphone. Is that better?
That is much better.
Okay, so
you may just need to speak up since it is a bit further away from you.
Okay. So I apologize for this. Now, we were talking about thoracic epidural as a regional anesthesia option for cardiothoracic surgery. And we were mentioning there are some contraindications that will limit the thoracic epidural. Patient refusing it, abnormal spine anatomy, the abnormal coagulation profile. And that's also have to be considered, especially for patients who are going to be on bypass or is going to be on continuous anticoagulation or going to be on antiplatelet therapy after surgery. Spine instrumentation in the past or spine tumors. These are common contraindications, but typically that is not the limit of the epidural. That does not limit the epidural. Okay. Now, the advantage of epidural on the other side, I think the biggest advantage with epidural is the familiarity, comfort, and trust for most anesthesiologists with thoracic epidural. Most of us have been trained on thoracic epidural, so we're very familiar with how to place them. We're very familiar with how to manage them, how to assess them, the assessment and management. We're familiar with the side effect and complication. So that's an attractive uh, point for epidural. Also, it can give you both side block by a single needle or a catheter. So a midline catheter can provide analgesia for both sides, one of the biggest advantage. Cover multiple dermatomes, and again, that also one of the big advantage. It gives you a widespread coverage. Block somatic and sympathetic, and we will talk about that in details in the next slide, but this is considered as an advantage as well as a disadvantage. Option to use different medications. So if you have a patient who are sensitive in terms of blood pressure, you can switch to opioids. You can use water soluble, fat soluble opioid. You can give clonidine. So you can use adjuvant in order to minimize the side effect of the medication. So that's another big advantage of the epidural. And if we look at the side effect, most of you are familiar with will be paresthesias, motor weaknesses, the opioid entity in the epidural, the nausea, itching, sedation, and respiratory depression. But more important that I want to touch base on is a sympathetic block. Now, a sympathetic block, if we look at the structures in here, coming out of the intervertebral foramen, you have the sympathetic ramus immediately anterior to the spinal roots. And this sympathetic ramus is also responsible for sensation coming from the visceral pleura as well as from pericardium. So advantage to block these is you're going to control pain, a visceral pain, not a somatic pain. However, the disadvantage is you're going to drop blood pressure. Now, is there a way to avoid this? And with epidural, it's almost impossible because you're going to get the spread from nerve root to the ramus. Even paravertebral, very good chance that you're going to have to block the sympathetic. You may start to negotiate that it is a unilateral sympathectomy. Yes, but if the incision is a midline, you're going to have to do bilateral. And there is an incidence that the local anesthetic can spread to the other side. And from a paravertebral, you're going to get bilateral sympathectomy. So the problem with sympathectomy is definitely the hypotension that happened, mainly due to the effect of local anesthetic on the sympathetic fibers. If the local anesthetic blocks the T1 to T4, that can actually also drop the heart rate. So that blocking the accelerator fiber, cardiac accelerator fibers, and you end up with bradycardia. So there is a hemodynamic changes in here that can be significant. Usually all this is tolerated in normal volemic patient. However, the treatment, which should be vasopressors to control the vasodilatation, usually end up by being fluid because it's easier, it's more familiar, it's safer to give fluid on a regular floor. And the fluid gonna lead to the interstitial edema and surge spacing, which does delay recovery. From that point, epidurals start to lose favor in terms of thoracic surgery. So you may try to with lower doses and it's still been done and still been successful. Now, what are other options? So again, if we're trying to avoid epidural and provide analgesia to thoracic chest wall, what are other options? The next option, if we're gonna go would be the paravertebral, and we discussed this. Paravertebral, if you're doing midline incision, you may end up by doing bilateral. You're gonna induce sympathectomy, which can go bilateral from one side as well. And from a technical standpoint, it is not an easy block. It's actually considered as an advanced block, even with ultrasound. Now, what else can we do? If we track, we're gonna find that the spinal nerves gonna give the dorsal rami going to the back, and it gave the anterior sympathetic ramus, and it's gonna continue after that as anterior or ventral ramus, running below the rib, taking the number of the rib above, and we name these an intercostal nerves. Now, they're gonna keep running while running in between the intercostal or between the ribs. They're gonna deliver lateral and anterior cutaneous branches. And these lateral and anterior cutaneous branches are the main sensory supply for the anterior chest wall. The intercostal nerves, you can do intercostal nerve block, but by looking at the anatomy, you're gonna find that already the intercostal, they do share with other intercostals. So there is a networking between upper and lower level. That's why it's a network between them. So if we decide that to do intercostal, we probably going to end up doing multiple intercostals. So even though it is safer than paravertebral with ultrasound, because we can easily identify the rib, we can easily identify the pleura, we're going to end up by injecting multiple injection typically. And the other downside of it, and I don't know if you can see it, but this space, the intercostal space, is highly vascular. So most of the local anesthetic gonna get absorbed quickly. That's why the duration or the half-life of local anesthetic in the intercostal space is very short, and the duration of the block is usually very short. So you may need to do the intercostal multiple times, basically. So what else can we do? Instead of intercostal, we can target the other nerves, which we call fascial plane block, the terminal end or the terminal nerve endings coming out of these intercostals. So this will be, if you're talking about lateral chest wall, anterior chest wall will be the pec serratus. And if you're looking at the posterior or the back, it's going to be the erector spinae block, basically. Now, what's the fascial plane blocks? So if you notice, we're not naming it as a peripheral nerve, we're saying fascial plane blocks because we don't have a formal definition so far of what are these. Target is usually a plane between the muscle that includes a network or a plexus of nerves before ending into their terminal branches. So we're not trying to block an identified nerve. It's a plexus of nerves. It is a volume and spread dependent since we're targeting a plane. Typically, we have to use ultrasound in order to identify the correct plane. Now, the pop technique or fascial pops or blind technique typically does not put the local anesthetic in the correct plane. Very hard to predict which muscle you're going through. So ultrasound is mandatory. And the name usually comes from the related muscle. So the muscle below it or the muscle superficial to it, and we put the name underneath. Now, these fascial plane blocks are for chest wall. We have for the anterior chest wall incision, there's a group of blocks. For the posterior, we mentioned the erector spinae. For the abdominal, we're not going to discuss today. Now, if you read in the literature the word interfacial plane, probably it is the same word for the fascial plane. They have been used simultaneously and interchangeable between fascial and interfascial because it gives the same concept. Now, the key for this is to understand the anatomy, to understand the muscles that constitute the chest wall. And what are these muscles? Where are the plexus of nerves runs so we can appreciate where to locate our local anesthetic. Now, if I start from the back, muscles of the back, we don't care much about except the erector spinae, which is on top of the transverse processes. If we move a little bit lateral, we're still on the posterior. On the back, you have the latissimus dorsi muscle, the huge muscle. And now you're going to find in front of it, underneath it, is the serratus. Now, the serratus is a very important muscle when we do these blocks, because this is the muscle that's immediately on top of the ribs. So if I took cut sections through these ribs, there's the ribs, intercostal muscle in between the ribs, and they are all covered with the serratus. The serratus is very thin anteriorly, and as you move posteriorly, there's an increase in the bulk of the muscle till it got inserted into the ventral surface of the scapula in the back. Now, this is an important because again, a lot of the injection depend on identifying the serratus muscle. Now, the serratus muscle is covered, as we said, posteriorly and laterally by the latissimus, the huge latissimus dorsi, anteriorly lateral by the major pectoralis or pectoralis major muscle, and in a certain area, it is covered also by pec minor. So you're gonna find areas where the rib are covered with serratus, then pec major, areas where it's covered by serratus, pec minor, pec major, and areas where the rib is covered by serratus and latissimus dorsi. That's why this understanding of the anatomy is very important. If you imagine the intercostal giving their branches, they're gonna give branches from underneath the rib. They form a plexus between the rib and the serratus. There is a plexus between the serratus and pec minor, and a plexus between the serratus and the latissimus. Now, if we move totally anterior, where there is no serratus anymore, and there is no pec minor, just the sternum and the ribs, you're gonna notice that the pec major is in direct contact with the rib and the intercostal muscle. And this is important when we talk about parasternal blocks for sternotomies, for example, that anteriorly you have only pec major covering ribs and intercostal muscles. Now, here's where we're gonna scan, and notice at this scan, I'm starting at the anterior chest wall by mid-clavicular line, more or less, just medial to the coracoid process. You're gonna notice the axillary subclavian artery. Caudate to it, you're gonna find the subclavian vein. People familiar with the brachial plexus blocks in the infraclavicular areas, they will identify this as the cords of the brachial plexus. Now notice at this level, you have the pec major covering the pec minor on top of the vessels. Now, where are the ribs? I cannot see it much, but to see it as we're gonna scan, we're gonna have to tilt the probe medially to see the ribs and the pleura. And the first rib you're gonna watch on the chest will be the second rib. The first rib is up in the neck. So the first rib we're gonna see is the second. And if you follow the caudate, you're gonna see third and fourth. Now let's run the scan and notice also there will be an acromiothoracic artery branches that are gonna come and run across these layers. So axillary artery vein, pec minor, pec major, acromiothoracic artery, and you notice the branches that come out of these. With a medial tilt, you're gonna start to notice the rib. And as a second rib, intercostals, pleura, notice the serratus. The serratus is very, very thin because we're anterior. And as we move posterior, the pec minor will end. And then the tip of the pec minor, you get to notice serratus is getting bigger and bigger. And it will be the major bulk of muscle in the mid-axillary to anterior axillary line, to be covered when we move posteriorly by the latissimus dorsi. So at this view, you're seeing the latissimus, serratus, ribs, pleura, and intercostal muscles. That's typically mid-axillary line or posterior axillary line. Notice all along these interfascial plane, you have vessel branches of acromiothoracic. And it's not atypical for nerves to run with vessels. We all know that. So if we talk again about the chest wall innervation, we have T1 to T6, and they are giving the anterior as well as the lateral, and they are communicating with each other. That's why we're saying we're not blocking a single nerve, we're blocking a plexus of nerves. So I cannot tell you which nerve I'm blocking, I can tell you which plexus I'm trying to achieve. Now, notice on the top here, you have other branches other than T1 to T6. So these branches are supraclavicular nerve. Supraclavicular nerve, as we're gonna discuss, are not actually branches from T1 to T6. So what are the other innervation of the anterior chest wall? So it's not just thoracic intercostal nerve. You have more innervation, which coming from the brachial plexus. And that even opens a discussion that these blocks may be better than an epidural because it can also block branches of the brachial plexus coming to the chest wall. What are these branches? The subclavian nerve, which is coming to subclavius muscle under the clavicle, medial and lateral pectoral nerve coming from the medial and lateral cord, and these are the main nerve supply to the pectoralis major and minor. So thoracic epidural may not give you the pectoralis, but these can give you the pectoralis innervation as well. Long thoracic nerve, which is coming down to give the serratus. So that also another nerve that is not part of T1 to T6, is not a thoracic, it's part of a brachial plexus. Thoracodorsal nerve going to the latissimus dorsi. So that's another one coming from the posterior cord. And also we have some from the cervical plexus. We have supraclavicular nerve, C3 and C4, that supplies the skin and subcutaneously below the clavicle. So in this discussion, by doing chest wall blocks, we're not just doing T1 to T6, lateral and anterior branches. We're actually doing branches from the brachial plexus that supplies the chest wall. Now notice in here, supraclavicular nerve are immediately below the clavicle. So if you're doing a surgery that's gonna involve the subclavius muscle, which I can think of a pacemaker placement, portacast placement, a TAVR that they're gonna go through the axillary or the subclavian vessels instead of going through the femoral, blocking the supraclavicular nerve is very, very important. Now, if we look at the long thoracic nerve and thoracodorsal nerve, we're going to notice that they are lateral in the chest wall. So any injection that's anterior in here will not be able to reach it. This is why when we do a PEC2 or we do a serratus, we try to go lateral and posterior, try to get our local anesthetic to cover the long thoracic and thoracodorsal nerve, which more or less in the mid-axillary to posterior axillary line. So our ultrasound gonna move from anterior to mid-axillary and posterior axillary in order to get this block. Now, this is a very nice review article by Woodworth that was published in 2017, tried to summarize what are these blocks and how they get their names. And if you notice, it's the same cross section. We have the pec major, the pec minor, then the serratus, and the intercostals. We're trying to, as we said, lateral cutaneous branch is going to be blocked with us when they come out of the intercostal. So at any layer we inject, we're going to have branches of these lateral cutaneous branches. Now the PEC block, the PEC 1 was to inject local anesthetic between PEC major and PEC minor, and that's going to give you medial and lateral pectoral nerve, basically. So that's an addition to the intercostals. PEC 2 blocks, if you go one layer deep, so if you go underneath the PEC minor, you're going to find the serratus, or if you are lateral to the PEC minor, it's going to be between PEC major and serratus. And this is, again, that's going to give us these branches. In addition, if you move lateral enough, you're going to get the long thoracic nerve that give you probably the anterior to mid axillary line. Now, if I move even further back between the serratus and latissimus, that's going to give us the thoracodorsal nerve, and that gives you the more posterior incisions, basically. Depend on the incision, we may end up doing PEC 1 and 2 and serratus, or PEC 1 and 2 only, or serratus only. Depend on how far lateral is your incision. Now I want to remind you again, supraclavicular and subclavian nerves are not branches that you can target by injecting here. They are actually very superficial. So an injection subcutaneously below the clavicle or even above the clavicle, immediately above the clavicle, can give you a sensory analgesia in this area if surgery is very high up in the chest. The medial and lateral pectoral nerve are underneath the pec major, so we reflected the pec major out. We have the pec minor underneath. So medial and lateral pectoral nerve are between pec major and pec minor. And then we're going to have to move lateral between the pec major and the serratus to get the long thoracic nerves. Another illustration between pec major and pec minor, we're going to call this pec 1. And pec 2 is if you go between a little bit lateral, posterior to the end of pec minor, so you're between pec major and serratus anterior. And again, you're close to the exit of the lateral cutaneous nerve. Where would be the ultrasound? Basically, it's going to be medial to the coracoid process, below the clavicle, as if you're doing infraclavicular. And then you start to count your ribs, you start to move lateral. You want to have some injection below the tip of the pec minor, so you get to the long thoracic. Now, if you advance even more, if you want the thoracodorsal, you have to advance more to get into the serratus plane block by mid-axillary line. Now, in this view, we were able to see the rib 3, rib 4, and again, we're trying to come near the tip of the pec minor to get the long thoracic, and also to avoid brachial plexus. So you're moving caudate to avoid brachial plexus. Now, with one needle pass, you can be between the serratus, and how do we know the serratus? It's the one that's coming on top of the rib, taking origin on top of the rib. Now, the thickness of the serratus varies. It depends on how posterior you are. The more posterior, the more muscle mass you're gonna see, as well as the incidence of the beam. Are you cutting parallel to the muscle? You will not see much. If you're cutting across the muscle, you're gonna see a better view. So tilting your probe while doing the scanning is very, very important because you want to appreciate which one is a serratus, as we said. Now, if you inject between the pec minor and serratus, this is the pec 2 more or less, that's the second injection, which by the way, pec 2 involve the deep injection as well as the superficial. So it involves both injection, if you say pec 2. And then you put some local anesthetic down in here, and on your way back, You put some local anesthetic between pectoralis major and minor to get medial and lateral pectoral nerves, basically. Now, want to keep an eye on the vessels that are on these planes, because it's very common to see branches, thoracoacromial artery, so you want to avoid it. It's run with a nerve, so you know that there are nerves around the arteries, but you want to avoid the artery still. Now, the injection should be in between the muscles, should not be intramuscular. So you're trying to go intermuscular. You try to separate the muscle with your injection, basically. Now, as we said, the long thoracic is a little bit further lateral, and it's the top of the serratus. And at this point, you're going to start to see the latissimus. So injection for the long thoracic and thoracodorsal, it has to be mid-axillary, to the extent that sometimes it's hard to do it even supine, and you have to turn the patient to their side. But that gives you good coverage to the lateral chest wall, basically. Now we're going to run a technique for the serratus. You can inject above the serratus or you can inject below the serratus. Both of them have been reported with very similar success. So you notice here we have the serratus muscle on top of the rib, and I am seeing the latissimus dorsi, so I'm mid-axillary more or less. So the first technique is to inject between the latissimus and the serratus, and that gives you the long thoracic and thoracodorsal. Not to mention also the lateral branches going to be in this area of T1 to T6. Now, some people have elected to go even further deep down to give some injection in there. And this is also to target more of the T1 to T6 plexus. As we discussed, there's a plexus underneath the serratus and a plexus above it. Some people have done both, so inject above and they go further deeper and inject between the rib and the serratus. So they divide the volume into two, basically. You can tell you're touching the rib with a needle, and then you're injecting, lifting up the serratus of the rib. Both of them gonna give you T1 to T6. However, if you want the long thoracic and thoracodorsal, you wanna give it into the higher one. Now, if we move to the anterior chest wall and we're concerned with sternotomies, it's important to realize the anatomy here is a little bit different. You don't have any serratus anymore. You have the pec major, there is no pec minor. You have the ribs and the sternum. You have three intercostal muscle in between the rib: external intercostal, internal intercostal, and innermost intercostal. If you're familiar with the tab block, you know that the nerve runs between the second and third muscle. Exactly for intercostal, the same thing. They run between the internal intercostal and innermost intercostal. Now, the innermost intercostal becomes very, very thin near the sternum to become very small layer that they change the name into transversus thoracis muscle. It is the same as innermost intercostal, almost the same layer. So the nerve run above the transversus thoracis muscle, underneath the internal intercostal. Now, from that perspective, you can put local anesthetic between the pectoralis and the intercostal, which is going to be the external. We call that pecto-intercostal. So you're one layer higher in here. And again, you're going to get some of these branches, or you can go even further down and give between the transversus thoracis and the internal intercostals. And that's going to get you actually better spread, more or less, because this is a layer where the nerve runs, and there are early studies showing that it has a better spread. Let's do parasternal scanning, see what we can find.
When scanning immediately lateral to the sternum, we can appreciate the pectoralis major muscle covering the ribs and the intervals between them occupied by the intercostal muscles. The intercostal muscles are made up of 3 layers, with the transversus thoracis muscle as the deepest of the 3. The transversus thoracis muscle is separated from the lungs only by the pleura.
So if we think of it, we have the pectoralis, then you have external, internal, intercostal, you have the transversus thoracis, and you can tell that the nerve running into these deep layers, and it gives branches up. So our injection can be between the pectoralis and the intercostal, just lateral to the sternum. We can call this pecto-intercostal, or we can go one layer deep. Not to mention that the vessel run into the plane where the nerve usually run. So you have the internal mammary artery, and we're going to discuss that, run on top of the transversus thoracis muscle. Now let's start with the pecto-intercostal. You notice that the probe is directly lateral and parallel to the sternum. You're going to see the multiple ribs, and you're going to see the pectoralis major, and you're going to see the intercostals with the pleura underneath. So you're playing for injection, and this is, again, to remind you, I'm trying to getting the anterior branches of T2 to T6, the branches that coming to the midline. And this is where we're trying to put our local anesthetic. And typically it's spread across multiple layers. And you can see this, the spread is typically over multiple ribs. So one injection is usually enough. The key here is that the injection has to be below the pectoralis. So that's to spread nicely. So in this video, I tried to demonstrate where we're injecting intermuscular versus intermuscular. So this is an accurate one between the muscle. This is a layer where we want to inject. And in here, we're going to try to make it inaccurate. So it's an intramuscular injection.
The video on the left demonstrates the accurate technique of the pecto-intercostal block. You will notice the separation between the pectoralis muscle and the intercostal muscles when local anesthetic is injected. The proper injection of the pecto-intercostal, or PIFB block, is the interval between the pectoralis major and the intercostal muscles.
Now, if you notice on the right, the local anesthetic is more or less intramuscular. It's not spreading and opening that fascial plane. And that requires definitely some training. Notice all this is an intramuscular
The video
injection.
on the right demonstrates an inaccurate injection of local anesthetic within the pectoralis muscle itself. The needle needs to be advanced to pass through the muscle.
Now, the transversus thoracis, again, we are going to go one layer deep. So instead of going between the pectoralis and the intercostals, we're going to advance and we're going to try to identify the transversus thoracis, and we're going to inject between the external internal intercostals and the transversus thoracis. Now, that provides better spread, and there is an early cadaveric work that's showing that it spread better than this. Not just this, you know, this layer hosts the nerves, the intercostal nerves. So it's a better layer to put in. However, the risk is, A, you have the pleura very close to your injection, you're a few millimeters away, as well as the internal mammary artery. So again, to emphasize, the pec intercostal is between pectoralis major and intercostal muscle. Now, the intercostal muscle are 3 layers on their own. So between the second and the third is going to be the transversus thoracis muscle.
The proper injection of the transversus thoracis plane, or TTP block, is between the transversus thoracis muscle and the rest of the intercostal muscles that lie above it. With this demonstration of the TTP block, the needle passes through the intercostal muscles, careful not to puncture the pleura.
Notice how deep was the needle. It's almost there. And if you notice, the spread is going
Proper
up and
injection
down.
should be between the deepest layer of the intercostal muscles, called the transversus thoracis muscle, and the other 2 intercostal muscles above.
Notice how close to the pleura. And you're gonna, when you inject, you're gonna notice that you're pushing the muscle away with the pleura. So this is a very good injection, and typically it go multiple layers. Now, as I said, the internal mammary artery is very close to this layer. It's in this layer, and it's 1 to 2 centimeters lateral to the sternum. So if you decide that you want to do this and you're going to go deep, be very, very medial, very close to the sternum, even touching the sternum, because laterally, and when you scan carefully, you're gonna watch that you're gonna see the lima and rima arteries there. So you don't wanna come close these for sure. Now, quick talking about the posterior uh, thoracic injection or the erector spinae. The erector spinae is more or less at targeting the dorsal rami, and some of the injection will reach up to the paravertebral space. So the use of erector spinae can be considered as paravertebral. If you do it a higher thoracic, you're probably going to get chest wall incision, especially as a posterior incision. If you do it mid thoracic, you're going to get abdominal wall. If you do it lower thoracic or lumbar, you may be even using it for hip surgeries. So it's more or less another route to the paravertebral space. Now the anatomy is very simple. We look at the transverse processes, which is you have to move from midline, and you're gonna identify the horizontal edge of the transverse processes, which differ from the ribs. The ribs are more rounded, and you're gonna notice the erector spinae and trapezius muscle. Local anesthetic need to be underneath the erector spinae muscle, basically. So again, here it's the position of the probe. It is a little bit challenging sitting. It can be done lateral and it can be done prone. Now we notice the erector spinae, we notice the transverse processes. We're gonna see where's the injection gonna be. Again, a lot of time you use the transverse process and try to hit the transverse process itself and then pull back a millimeter or so off the bone and then start your injection. So most of the time we do touch the process, the transverse process. And then we're going to see the injection and see how the injection is forming a nice layer of local anesthetic underneath the muscle, spread along the muscle. And as I said, that's mainly to get the dorsal rami as well as a posterior chest wall incision. Now, there are some studies showing that it does spread along this for 3 to 5 levels, so it can be good. If you go further lateral, you may end up being an intercostal. So you're trying to also stick to the midline as much as you can, just off the spinous process on the transverse. So to conclude, so we can have some time for question and answers. It's a new concept of regional anesthesia. We're looking at avoid the epidural because of all the side effects, especially the sympathectomy that leads to hypertension and can lead to a fluid overload. There's no specific dermatome. It's a distribution, it's a patchy distribution. The more local anesthetic we're gonna use, the more we're gonna get. We just need to put the local anesthetic closer to the plexus as much as we can. These are mainly formed of thoracic anterior primary rami, T1 to T6. However, there are branches, as we said, from the brachial plexus, which is an advantage. It is a volume dependent. And definitely ultrasound is necessary, especially if you try to identify these muscles. As you notice, even with ultrasound, we may have a hard time to get the local anesthetic in between the muscle, not intramuscular. So ultrasound is necessary, and definitely I believe most of us now are developing our skill with ultrasound, so we are more familiar. So hopefully one day we'll be as familiar as epidural with these techniques. Now the indications, limitation, and advantage are still evolving. So we're seeing more and more literature about chest wall blocks. When do we use it? When we should not use it? What's the limitation? I'm sure they are not the answer for all the problems of acute pain, but there's definitely one way to control pain without an epidural. And I will give it back to Adib for the question and answer.
Thank you, Dr. Soliman, very much for this informative presentation. We have like 14 minutes for questions, so don't forget to write down your questions. This is your chance. I'm going to start off with an opening question. What are your protocol for anticoagulation in chest wall blocks? And do you consider these type of blocks superficial or deep peripheral blocks?
That's a good question, Adib. Well, unfortunately, ASRA does not have very clear guidelines for anticoagulation as we have for epidural, neuraxial. But the guidelines for ASRA are giving you or are allowing the clinician to judge, is it a superficial or a deep? So for most of my practice, I would say a PEC and serratus are more or less superficial blocks. So if I can, most of the time, if I can compress on a hematoma that I induced, I consider that superficial block. So if I can compress on the pectoralis and I compress it against the chest wall and I can stop the bleeding or hematoma from developing, I consider that a superficial block. Needless to say, if you're gonna start to move into back intercostal or you're gonna do the transversus serratus, for example, somebody on anticoagulation and I got into the transversus serratus and I got the lima, consider that a deep block. I mean, it could be a few centimeters below the skin, but it's still a very deep block because you will not be able to control the bleeding at this point. So clinical judgment is important, and the degree of coagulation, definitely with these, we are more or less liberal with the anticoagulation. But again, take your clinical judgment. How bad is the coagulation of this patient? Is he a patient who oozes from any needle stick and he keep oozing? Then I wouldn't do any of these. But for the majority of patients, I think these blocks are very safe.
Thank you. I have another question from the audience who's asking, as a substitute for a thoracic epidural, would you perform for cardiac surgeries a PEC1, PEC2 in combination with a serratus block, or would you only just do a serratus block?
Hard to answer it unless you tell me the exact position of the incision. So as we said, if my incision, let's say it's starting from mid-clavicular and ending laterally to mid-axillary line. So for incision like this, I'm going to do PEC1 and PEC2 because the pectoralis have been cut. So I need to do the PEC2. And again, I try to emphasize the idea PEC2, it involves both injections, the deep and the superficial. So PEC2 and serratus. So for me, that's easy. Now, robotic cardiac surgery, where they only have their chokers through the pectoralis. They didn't come near the mid-axillary. So I don't need a serratus at this point. I mean, it's going to be just the pecs at this point. Chest tube pain, that's what's hurting the patient most. Probably serratus is enough. Incisions that start anterior axillaries, like most of the VATs, they start anterior to mid-axillary. Probably serratus is going to be enough. So you judge based on the incision and how extensive it is.
Okay. And what kind of probe do you use for these type of blocks? Do you use a curvilinear, linear probe, or what, in your experience, what do you use?
So for the majority of these blocks, they are 2 to 3 centimeter deep. So it makes sense to use the linear probe. Now the linear probe gives you better definition of the layers of muscle. So that's an advantage. Also, it's easier to follow the needle and track it. So most people will use this. Now, is there a morbidly obese and you're doing erector spinae and you cannot see much of the transverse process? Yes, then the curvilinear may have a role in this. But for most of the PEC, serratus, or the parasternal blocks, usually a linear probe is efficient.
Okay. And do you have any suggestions specifically for chest tube pain after cardiac surgery? Since one of the audience was saying that if he tried using a fascial plane block, such as an erector spinae serratus plane block and pecto-intercostal catheters, and it didn't help with his chest tube pain.
Well, we have actually experienced very good success with serratus for most of these chest tube. I mean, we end up by doing serratus block and it worked well. Now, also, again, you have to consider your volume, how much you are giving to expand the volume. And the more volume is the better in these cases. Now, for sure, intercostals can work. There's no question you can inject intercostal. However, you're going to have to do multiple layers. So let's say you have your chest tube between T5 and T6. You're probably going to end up doing T5, 6, 7, or T4, 5, 6, 7. So you're going to end up 3 or 4 levels. And at the same time, the duration of it, it's not going to be as long. So we actually have better success with injecting a serratus block for the chest tubes. And typically it will last enough, to last long enough. And catheter have been placed successfully in these scenarios.
Okay. There was also a question regarding the volume and concentration of local anesthetics that you typically use. Is there any preference you have?
Yes, I mean, I have the personal preference, but there is no really a literature guideline for this. But since we are all new to these fascial plane blocks, I typically try to inject more than 20 ml, 20 ml or above per each injection. So 20 ml or above per each injection. So if I'm doing PAC 1, 2, and serratus, so this is going to be 60 ml total. Is that based on any literature? No, but it's based on just experience that 20 ml is enough volume to expand the space. Now the dose itself, you're gonna have to calculate your dose based on the body weight, and then you dilute to achieve the volumes that you wanna give. So basically put as a 2.5 milligram per kilogram for bupivacaine, for example, if you're using it, see how much in milligram you're gonna use, and then you dilute it to the volumes that you need to achieve. Now, if you do a continuous catheter, now it's a different scenario because you have to look at the infusion rate and still, again, look at the guidelines for the medication you're using, basically.
So we have a lot of questions, Dr. Munir, and I'm gonna just stress upon one which they asked like twice. Is there a difference? Is there any evidence showing that placing in a serratus plane block, placing the local anesthesia above the serratus versus deep to the serratus, is there any evidence that one is better than the other?
Well, the original publication on serratus block was a group who did it, I believe, on 11 or 12 patients. And the same group did it between the serratus and latissimus. Then they repeated the study and injecting below the serratus, so between the rib and the serratus, lifting the serratus. And they reported actually very similar results, very comparative results. Anatomically, in my mind, again, if you inject below the rib, below the serratus, above the rib, you're getting the T1 to T6 branches. Great. But you're not getting the long thoracic or the thoracodorsal. So even if you want to inject below the serratus, my advice based on anatomy, if you're trying to get the long thoracic and thoracodorsal, they run one layer above. So they run between the serratus and latissimus. So you still need to put some local in there.
Yeah. And for pecto-intercostal fascial plane block, do you have to do more than one injection or is one injection enough?
Typically one injection enough, and actually you can track it with ultrasound and you can advance your needle. If you're not feeling like it's spreading as it's supposed to, you can keep tracking with a needle and follow it with the ultrasound to see the spread going up and down. But typically I go to the mid sternum, so somewhere in the middle of the sternum, and we just one injection. Now the key here, are you into the fascial plane where it's supposed to be? Because if you're into the fascial plane between the pectoralis and the intercostal, the more volume you're gonna give, the more it's gonna dissect between the muscle. The problem comes when you're injecting into the muscle. At this point, it is limited to where your injection is. So again, if you don't see it dissecting the muscle appropriately, you probably intramuscular and you need to advance a little. And again, ultrasound nice in detecting the spread of the local anesthetic.
There's an interesting question regarding serratus also. Do you have any experience with serratus catheter versus liposomal bupivacaine? And which one do you actually prefer?
Now, we've been using both, and I will be lying if I tell you I know the exact answer or the correct, but we have been used both, and both of them in different occasions are successful. Now, the catheter technique, what we noticed that the intermittent bolus works better than the continuous infusion or the PCEA, that the patient have a continuous rate and a small dose in between. We figured that actually the intermittent bolus with a large bolus works better for this technique. And it does just make sense that you give a bigger volume of a long-acting local anesthetic, even if it's 2-hour period in between, it does spread better. So that's our experience with catheter.
Yeah. And what about out-of-plane technique in these chest wall blocks?
Well, we have to remember that out of plane, in plane is just how are you getting your needle to the planes that you want to get to. And that depends on your experience. Now, the out of plane is not an easy technique. It actually requires a lot of training. And to be able to avoid too deep of an injection, especially too deep here can mean intrapleural. So I wouldn't suggest it at the beginning. I would suggest people get comfortable with the in-plane. However, it is just the way you like to introduce your needle and the way you're comfortable introducing the needle. If you get the local anesthetic into the correct plane, still gonna work.
Okay. And I have another question about indications. For what procedures are you using for PEC 1 versus PEC 2? And what procedures do you use for serratus block in your practice?
Okay. So if we think of the PEC1 as giving medial and lateral pectoral nerve block, that only covers the pectoralis, major and minor. So you have to have a superficial incision that does not dissect down. So that can be a pacemaker placement, could be a mid port placement. But if the incision gonna go deeper than this, you need the T1 to T6. So you're gonna need the PEC2. So that's in terms of PEC 1, PEC 2. Serratus all depend on the incision. Most of chest tube are anterior to mid-axillary, so that's great for it. A lot of the VATs, video-assisted thoracoscopy, are in this area as well, so we do inject in there.
Okay, and there's a question about comparing ESP versus serratus block. Is there any consideration regarding spread of anesthesia? The audience found that ESP in his experience often does not provide good anterior coverage. And there has been recent studies to show haphazard spread of the ESP block.
I agree. I mean, again, the ESP probably getting you the posterior ramus very nicely, but the posterior ramus are limited to the back, to the posterior part of the chest wall. Now, when it's spread anteriorly, it's really when it reaches the paravertebral space. So if your local anesthetic is able to get access to the paravertebral space, this is where you can get a good block for anterior incision. So the ESP by default, by definition, if it's a pure ESP, is not good into reaching the paravertebrals.
Okay, thank you. Another question, we have like 2 minutes left. So some practices are performing erector spinal facial plane blocks for spine surgeries. If there's a lumbar spine procedure, would you suggest doing a bilateral ESP in the lumbar level, or is there any other level you would do
Actually,
this block?
that would be perfect for lump. Again, remember now we're trying to target the erector spinae muscles for spine surgeries. So this is a perfect because you're getting the dorsal rami, and you would like to put it where the incision going to be. I mean, it is very corresponding to the dermatomal. The level of the nerve is very similar to the dermatomal distribution of the incision at this level. So it would be perfect to do it lumbar for lumbar surgeries.
We can have one more question because we are running out of time. We have a lot of questions, by the way. So, in this question is for a radical mastectomy, are there any additional blocks you would perform in addition to the PEC2 block?
For mastectomies?
Yeah, for a radical mastectomy.
Yes, because the radical, actually the incision goes lateral to the axilla. So to get the lymph nodes, the serratus at this level will be indicated because at the extension, and now you want the long thoracic nerve because the long thoracic nerve is going to be involved. So you're going to need a serratus in addition to the pecs.
I think we're out of time. We have a lot of questions left. I'll try to answer them
The chat.
in the chat. However, I would like to thank you very much, Dr. Soliman, for this informative presentation. And on behalf of ASRA, I would like to thank everyone for showing up to our webinar, and I hope you enjoyed it.
Thank you, Adib.
Thank you so much.
Everyone.
Have a great night.
Thank you.